Hi, now we're looking at week 8, and we're looking at substance abuse and substance-related disorders. Now, this first video, I'm going to look at the sort of categories, and it's a little bit different than some of the other psychological disorders in that most of us have probably been familiar with people who have used different drugs, marijuana, hashish, alcohol, nicotine, but also some other things potentially, either hallucinogens and stimulants and depressants. And it doesn't seem right, in a sense, to categorize it as a disorder, a psychological disorder. But what we're going to be looking at and want you to pay attention to, that each and every single one of these, in and of themselves, you might say, well, everybody does this, or it's not a big deal. But the key is around looking at psychological dependency and physiological dependency. Now, the difference between somebody using and somebody abusing, you have to fall back on what we talked about in the very first week around what makes up a psychological disorder. It's somehow damaging to themselves, it puts them at risk, it affects their everyday life. And so people who come to be in this category are using to the point of those sort of check marks being checked off. And so this is not the same as somebody going out for a drink or somebody who engages in some narcotic drugs periodically. This is different. This is somebody who uses to the point where it interferes with their everyday life, their relationships, their ability to do their work, the ability to engage in social activities, maybe even to the point of risking their health, and it involves the psychological and physiological dependency. So that's what we're going to do in the first one. I'm not going to go into great detail. A lot of it is in your textbook around the, what it is and what they do, in terms of the different drugs. And you've probably in your course of your education through high school have heard the do's and the don'ts of different drugs and such. So I won't go in great detail. Any other detail that you may want to get in terms of clarification, please look in your textbook. Alrighty, let's get on with it. The DSM uses two major categories for substance-related disorders. Okay, now there is a substance use disorder, which is the number one substance abuse disorder, and it's patterns of maladaptive behavior involving the use of psychoactive substances. And the substance use disorder includes substance abuse disorder and substance dependence disorder. And so when we look at this, it continued to use the psychoactive drug despite the knowledge that it can cause or is contributing to a persistent and reoccurrent social, occupational, psychological, and physical problems that in spite of knowing this, we carry it on. And that's what a substance use disorder is. Now, the second type is known as substance-induced disorder. And here the disorder is induced by the use of psychoactive substances. This includes intoxication, withdrawal syndromes, mood disorders, delirium, and amnesia. Now, along this line, or with substances, there is what's called intoxication. This is a state of drunkenness or being high. So what intoxication will look like really depends on the substance being used, the dosage of that substance, and the person's reactivity, and to some degree, the user's expectations. Extreme intoxication can lead to death. Substance use disorder may continue over a long period and can progress to more severe, severe progression, even to feeling helpless to control their use. Now, you'll find on page 250 in table 7.2 the criteria for alcohol use disorder. Now, there are some basic elements or hallmarks of substance abuse. And there are physiological reactions to prolonged use of substances leading to the development of tolerance and withdrawal, which are two big issues when it comes to substance abuse. The top 3 commonly used drugs in North America are tobacco, about 25% of the population, alcohol, about 15% of the population, and marijuana, about 5% of the population in North America. Now, tolerance. This is the physical habituation of any substance, drug or alcohol, with frequent use and the use of higher dosages which are needed to achieve the same effect as had been before on fewer and less. The other term that's associated with the other sort of component is that of withdrawal syndrome. And withdrawal syndrome has the characteristics when the person stops abruptly from a substance after they have been using it for long periods of time in heavy use. The symptoms will vary according to the substance being abused. In alcohol abuse, it will include nausea, weakness, and what is known as tachycardia. It's an abnormally rapid heart rate. Increases the likelihood of anxiety and depression and insomnia, and in some cases withdrawal will include delirium tremens, known as DTs, and delirium, which is essentially disorientation and incoherent speech. And so these are typical of substance abuse in terms of criteria or for expectations of the experience over a longer period of use. Some other terms that are important to know, of course, is addiction. People define addiction in different ways. For our purposes, we're going to define it as the habitual or compulsive use of a drug accompanied by evidence of physiological dependence. Now, there's some key points there. Habitual just means habit forming. It's like getting up in the morning and lighting a cigarette. When you're a smoker, you know what I mean. Well, in this case, it's with other substances, not excluding tobacco, but it becomes that habitual. You know, the after meal, the later in the evening, the before you go to bed, they become habit forming in terms of time or place, circumstances, or with people. The compulsive use is the if I don't get this now, it's preoccupying my thoughts. And it becomes something that if I don't satisfy those thoughts, it becomes very anxiety producing. Now, the major signs of addiction include signs of physiological dependence. This involves the development of tolerance and or a withdrawal syndrome, abstinence syndrome. So physiological dependence becomes where your body is in need of it. It's not any different, really, that when you're thirsty and you're really thirsty, your body starts to cry out. You get a dry mouth. Your body and your mind starts to think about, well, this is what I'm missing, I need, so you need to go get. And it's a physiological dependence in this instance that the substance that you're missing becomes something that you hurt for, if you will. The other side of the dependence is that of psychological dependence. It's involving the pattern of compulsive use associated with impaired control over the use of the drug. And these are two things to really keep in mind. Well, actually, these and the other hallmarks mentioned in the previous slide are things to remember when looking at substance abuse as a psychological disorder. Now, there's different pathways to this sort of dependency. Experimentation is probably one that we're familiar with. This is the occasional use, the temporary feel good. The user feels like they're in control and believes they can stop at any time. And a lot of the time, that's in fact the case. Over time, experimentation can lead to more routine use. Lives begin to be structured around the pursuit of or the use of drugs. Denial plays a big role here. You know, oh no, I could stop any time, and you're using it on a daily basis. You may even begin to cover up and saying, well, no, that wasn't something I did today. That was from last week. You know, things that were once important, things like family and work, they are less so. You might even miss certain meetings, or you might not attend work because of the routine use and the side effects of those routine uses. The choices are dominated by drugs, spending, spending on the time related to drugs and alcohol, straining relationships with family and friends, and unexplained absences. And for a smaller group of people, experimentation to routine use can lead towards addiction or dependence. Once a routine user feels less powerful, in fact feels powerless to resist the drugs, either for the effects that the drugs give or to avoid the experience of withdrawal. So drug abuse carried on, we can look at some types. We're going to start with depressants. Now, depressants usually include alcohol, sedatives, minor tranquilizers, and opiates. So when we think in terms of, alcohol is a very common one. The effects of alcohol intoxication includes intoxication, impaired coordination, slurred speech, the impaired intellectual functioning. Now there are, if you will, associated with this risk factors to alcohol. Now one of the first that's often looked at in terms of the demographics in any particular area that you're looking at in regards to alcohol would be gender. And interestingly, when it comes to alcohol equity, there's a fairly equal distribution between men and women in the use of alcohol. Women tend to start later, but alcoholism moves more quickly for women. Another factor is that of age. Young adult, before 40. The beginning in late adolescence and somewhat later for women tends to have a higher risk. Antisocial personality disorder has an impact. Family history is best predictor for problem drinking in adulthood. By example, that is to say that when we see drinking around us as children, we become more, we can see it as a social experience that can be modeled, or perhaps some biological predisposition could be occurring. Also, there's the sort of socio-demographic, or the areas around social experience. There's an increased risk of alcohol use among people with lower income and with lower levels of education. Now again, this doesn't mean that everybody in these circumstances are automatically at higher risk, but these are the demonstrated risk factors when it comes to the use of alcohol. Conceptions of alcohol, I'll start with the medical model, where it views alcoholism as a disease. It's permanent, it's irreversible. Essentially, once an alcoholic, always an alcoholic. Now there's a historic perspective that introduces it as a moral defect. I think we can find that research has suggested that that's not a strong position to hold anymore. There is also a behavioral sort of component to this, and that is the self-fulfilling prophecy. Now if we look at some of the other effects like psychology, or the psychology effects, we have the stereotypical alcohol will reduce the tensions and the worries. If you're a tense person or you worry a lot in a social situation, well, alcohol will make it more relaxed. The increased pleasure in social interactions, in fact, can be more detrimental. The notion around short-term pleasure being more accepted in a social environment can bring about long-term pain, and that it could turn into a routine use and perhaps even addiction and dependency. Chronic alcohol abuse has been connected with disorders such as alcohol-induced persisting amnesic disorder, which is also known as Korsakoff syndrome, cirrhosis of the liver, and other physical disorders, and along with fetal alcohol syndrome associated in terms of some of the other physical effects. Now, can somebody moderately drink? Well, the simple answer is, as pointed out there, is yes, but it's a slippery slope. Yes, there is some research that supports moderate drinking, and it has some guidelines around how much alcohol per day could be reasonable. The risk, of course, is any of the other associations that we'll start to make in regards to risks of alcohol abuse. Alcohol plays a role in the deaths due to snowmobile accidents. About 77% of the cases, alcohol is involved. Homicides, over 50% of the cases. Traffic accidents, over 40% of the cases. boating accidents, about 40% of the cases, and suicides, about 20% of the cases. We'll look at barbiturates next. Now, barbiturates are depressants or sedatives that have been used medically for the relief of anxiety or short-term insomnia, among other uses. They can become psychologically and psychologically and physiologically dependent on both in terms of tolerance and the development of withdrawal syndrome. Opiates, or they're also known as narcotics, such as morphine and heroin, are derived from the opium poppy. Others are synthesized, and they're used medically to relieve pain. It's known as analgesia, and they are strongly addictive. This image here shows the pain signal coming in through the neurons and along the brain, in the brain cells in the brain, and then looking at how the endorphins, which are the things that can help block those pain signals. We'll move into stimulants. These increase the activity in the neural system. Now, amphetamines, cocaine is among the stimulants as well, increase the availability of neurotransmitters in the brain, heightening states of arousal. High doses can produce an amphetamine psychosis, which mimics features of paranoid schizophrenia. Cocaine, it's produced from cocoa leaves. It can be snorted as a powder. It can be injected as a liquid, usually used through a process called freebasing and the use of ether, or it can be smoked in a hardened form called crack. Cocaine produces a high by stimulating the neurotransmitter dopamine, resulting in high blood pressure, accelerated heart rate, and reduced blood flow to the heart. Overdosing can include insomnia, restlessness, nausea, tremors, hallucinations, even death. Now, another form of stimulant is nicotine. The repeated use of nicotine, usually in the form of cigarette smoking, can lead to physiological dependence. And if you look on page 266, figures 7.2 and 7.3, you'll see some charts associated with stimulants. If we move into hallucinogens, also known as psychedelics, including LSD, psilocybin, and mescaline. Other drugs with similar effects are cannabis, also known as marijuana, and PCB, phencyclidine. If we look at LSD as an example, as one of the hallucinogens, it appears to decrease the serotonin action and increase dopamine activity. Now, one of the results that can occur for some people are what are known as flashbacks, or the re-experiencing of some of the distortions from a past trip that happened days, months, or even years earlier. They are sudden, and they are a result of chemical changes in the brain. PCP began its life in the 50s and as an anesthesic. It was discontinued when it was discovered its hallucinatory effects on patients. It's very unpredictable. The effects are very unpredictable, which can vary in terms of increased heart rate. Blood pressure is also increased, but it's also capable of producing states of delirium. And marijuana, which has a psychoactive ingredient, THC, the proportion of marijuana users in Canada is much higher among young adults in the population as a whole. Dependence is associated with the psychological and physiological dependence. Now, hashish is also derivative of marijuana from the marijuana resin and has a very similar experience to marijuana. Inhalants. Many substances can be used that produce fumes, adhesives, aerosols, cleaning fluids, fuels, many others. These are inhaled and can induce feelings of intoxication and euphoria by their actions on the GABA, the GABA, and dopamine systems. The psychological and physical effects of inhalants can be very serious and even with can be fatal with just one use. Now, this has been an overview of the types of drugs that can produce substance-related psychological disorders. They're not limited to these, and certainly if you've been through in your high school career, I'm sure, a lot of seminars or workshops on the risks of drugs and alcohol. This would be more of the extreme risks associated with drugs and alcohol. All right, let's carry on, and we'll go to video 2, which will look at theories, and then video 3 will look at treatments. Thank you, everybody. Bye now.